Good morning, everybody, again. Welcome to the second session of the GFRA Forum. And I would like to ask you to please take your seats. But then half the people are just going to leave. I don't know if that serves the purpose, Pascal. Before we start, Alejandra asked me to remind you that we're looking for followers for our social media. The goal of 100 new followers had been identified previously, and I think we've only made 20 since then. So you people still have a ways to go. And if you want cocktails at the end, better hit the like and follow buttons out there. All right. Again, welcome to the second session of the GFRA Forum. Our focus now is going to be FMD control through improved diagnostics. And in the spirit of this whole forum, it's about going beyond research, particularly with diagnostics. If you follow the literature, there is a lot of improvement. There's a lot of progress being made. A lot of assays are being developed, they're being presented. But very rarely, if ever, are any of these innovations in research then translated into products, and in particular into products that are then being used in the field sustainably. And this, I think, is a missed opportunity in many cases, and we really need to explore maybe what some of the roadblocks are preventing this innovation in the research space from actually becoming useful for FMD diagnostics and, by extension, FMD control in the field. We're going to have three speakers in this session. The first one will be Bakkali Kassimi of the European Union Reference Lab for Foot and Mouth Disease. And I would like Labib to please step up to the podium.
Hi everyone, good morning. So first I would like to thank the GFRA organizers and also the FMD for giving me this opportunity to be here with you today and to present you this presentation that Mikhail invited me to give you this presentation. This presentation will not be exhaustive. I will not present to you all the improvement, but I will try to give you some information and what has been done and maybe some direction for the future. As we saw this morning, but also during the two last days, the control of FMD is something very complex. It's very complicated. And the diagnostics in the laboratory is only one component of the control process. So we need also the laboratory and with also some diagnostics method and improvement of diagnostics to help in the control. So my first slide, I take this picture from Don, who presented this, I think, about 10 years, more than 10 years ago. And usually he showed this iceberg, and you can see that there is low cases reported of FMD, but there is many cases that are unreported, unsampled, and this is represent a lack in the control of FMD. And the main problem for this, as we saw this morning and also during this, is because for some countries FMD is not a priority, and also there is some research constraint to implement control measures, but also some difficulty to access some area to control the disease, and also the lack of laboratory capacities in endemic countries to do the diagnostics, and also some difficulty, even if they can sample take samples, they have difficulty to ship these samples to reference laboratory to do diagnostic and characterization of the strand because the cost of the shipment. So during this few years ago, there is several studies conducted to improve this kind of, or to address these issues, in particular for sampling, for shipment of sample, for diagnostics, and to improve the diagnostics to help people to be able to diagnose FMD easily. So the process for FMD diagnosis, as you know, you have suspicion that you have in alert for the outbreak. So the veterinarian would go to the field to take samples. This is another issue, that to be able to go to the field and to take samples, because this is also needs some resources, but I will not talk about this. Then they have to package the samples and ship the samples to laboratory to do diagnosis. So the first question that the laboratory should ask, should reply is it FMDV or not? And if it is FMDV, the laboratory should identify the serotype to implement control measures based on the vaccination, for example, but this also need strand characterization for the selection of the good vaccine strand to be used in the field. But also the strand characterization will help to understand the dynamic of the virus in the country or in the region, and also to do some phylogenetic analysis. So currently we have several diagnostic tools available in the laboratory to do this, all this analysis. And I can tell you that when I started working on FMDV, the first surprise that I had, this was 50 years ago, my surprise is not to see a lot of commercial kits available in the market for the diagnosis of FMDV. And after that, because I have chance to have also some colleagues working on blue tongue virus in our lab, when the blue tongue arrived in Europe, there is many PCR kits in the market, many serology kits in the market, and this is not the case of FMD. And we saw also with the COVID, when the COVID arrived in Europe and all in the world, there is many development of kits for the COVID in short time, but also vaccines, new vaccines. But this is not the case for FMDV. Ando said this morning that FMDV is the first animal virus discovered in the world. It is in 18. But until now, we still lack many diagnostic kits for FMD. So currently, the laboratory to diagnose FMD, they have to look for live virus. They can look for viral protein, and also for genome of the virus, but also it can look for antibodies. So the laboratory can use virological molecular methods or serological method to diagnose the virus. So for virological method, for detection of live virus, we can use virus isolation on sensitive cells. And this method can be used to detect the virus, but also to amplify the virus that can be used after that for vaccine matching, for example, for production of vaccine, for example. And today, there is some development of the cells that can be used for isolation, and we saw the presentation of Valerie from the World Reference Laboratory, that there is many cells that are available to isolate the virus. And in the past, the cell that was recommended was the primary bovine thyroid cells. But today, there is many cell lines are available to isolate the virus with different sensitivity, like LFBK, the ZZR127, IBR, but also some people still using BHK cells. But when you get cytopathic effect, because the virus lyses the cells, you have to confirm that this lysis is due to FMDV. So you need another method after that to confirm that this is really FMDV and not other viruses or toxicity or something. We have in our hand the antigen ELISA, which is a capture ELISA that will capture the antigen. And this method can be used to detect and type the virus, and we can detect FMDV specifically, and also we can identify the serotype by using specific antibodies. And in the past, we had only a polyclonal antibody-based ELISA that used rabbit and guinea pig antibodies. But today, we have some kits available on the market that use monoclonal antibodies that is more easy to perform and is also sensitive. But this method to use directly on the samples from the field need that the samples be rich on the virus, because the sensitivity of this method is not very high, but it can be used. But this method also can be used after virus isolation to confirm that it's FMD, but also to type the virus. Other methods are the molecular method. The first one that is widely used is real-time RT-PCR that today is used in many laboratories, not to say all laboratory, but it's used in many laboratories. And this method can be used to detect, but also to type the virus. But unfortunately, until today, we don't have a specific real-time PCR for a serotype. We have some real-time PCRs that are under development or developed to detect the topotypes. If you remember the presentation given by Guillaume for development of topotype-specific real-time PCR for topotype SAT2, topotype 5, for example. So this are in development, and this can help to type the virus. The other molecular method, a conventional RT-PCR, this is also a method that can be used for detection and also typing. We have developed conventional RT-PCR for typing FMDV that are circulating in West Africa. So this is also a method that can be used to target specific strands that are circulating in some area, because we don't have today conventional PCR for one serotype. But also the conventional PCR can be used to amplify the VP1 sequence, and this amplification can be, the product of this amplification can be used for sequencing and do phylogenetic analysis. For serological method, we have two kinds of serological method. We have method that can detect antibody directed against non-structural protein. Non-structural protein, the protein that are used by the virus for its replication. And these antibodies are produced when the animal is infected with the live virus, and not produced when the animal is vaccinated with inactivated and purified virus. So this is the DIVA test that is specific to all serotype, can use for any serotype, but also not specific to species, that can use for different species, but should be validated, of course, on different species. The method that we have to detect antibody against structural protein, the structural protein is a protein that forms the capsid. So this test, we have two kinds of tests today. We have ELISA tests. We have the SPCE and LPBE. This is ELISA that is based on using of polyclonal antibodies, guinea pig and rabbit. But also now we have some commercial kits that are based on using of monoclonal antibodies that also easy to perform and also help on improvement of diagnostic of FMDV by serology are rapid. And this method are also can be used for all species, but are specific to the serotype. And we have the gold standard, which is virus neutralization test. But this method needs a high containment laboratory like the virus isolation, and can not be used in any laboratory. That laboratory should have a high containment facility. So now, what the new approach that are under development or developed? I will show you three kind of approaches that are under development. The first one regarding the diagnostic method. So there is some papers have been published on the use of RT loop-mediated isothermal amplification that can be used in the field, and this method not necessitate a high quality, a high material that use only a small system to perform, and can be performed at one temperature that is different from the real-time PCR, and can be used in the field in a mobile laboratory, for example, as you can see in this picture. This is the first method for molecular method that has been developed for to move the diagnostic in the field and to give possibility to laboratory, to country with low resources to do the diagnostic. Recently, in 2023, a new method have been published, and also the one material, that is called Picogen PCR 1100. It's a system that can be used to perform real-time PCR in the field in 60 minutes. So this is a material that uses microfluid system and is easy to perform, and also that can be used reagents that are lyophilized and are stable at room temperature. And this is also, for me, a new improvement of diagnostics, because we can have a high sensitivity method in the field and can be used. And the third method that have been developed, and for me this is one of the methods that's really very, very useful, is the lateral flow immunochromatography test that have been developed, and today they have some LFDs that are available on the market, and this can be used in the farm and don't necessitate high scale of knowledge. That can be used easily, and this today we have LFD that can be used to detect the virus but also to type the virus. So this is nice, very nice. We have method that can be used rapidly in the field. But the main issue for me, what to do after. You can detect in the field FMD, but if you don't implement immediately, rapidly the control measure, what is the advantage to have a test in the field? So we have to think also about the improvement of the control, and also to encourage country to implement control measure in the field, not only to test in the field, but also to implement rapidly biosafety measure and also control measure. So the other issue that I said is the difficulty for shipment of samples to reference laboratory, and I remember the presentation given by Aurore on the inactivation of LFD. So this is one of the issues, is also the difficulty of shipment of sample. It's not only because it's banned by some airlines, the cost of shipment, but also in some countries they lack packaging and they lack dry ice, so they have to import dry ice to import packaging when they want to send to ship the samples. So this is created delay in the shipment, but also difficulty for shipment. So here I show you three approaches that have been investigated to facilitate the shipment of samples. And the three approaches claim that they can inactivate the virus in the samples, and also the samples can be shipped at room temperature. The first one is the FTR card. So there is some publication on the use of FTR card for shipment of samples. And if you see all the company that sell this FTR card, they said that the virus can be inactivated on the FTR card. But there's a publication by Michael here who showed that it depends on the FTR card. The inactivation of FMDV in FTR card is not the same in all the FDR cards. So depending on FDR card, the inactivation of the virus can be on one day, but some of them you have to wait 1 month to inactivate completely the virus. And this is I found only 2 publications that show that the virus is inactivated, but for only serotype OA Asia, but not for other serotypes. So this need to be also validated. We have also the LFD, the inactivation of FMD on lateral fluid device with citric acid, the presentation given by Aurore, and this was intensively validated. And we have also a publication on the inactivation of the virus on the epithelium, for example, by putting the epithelium in chemicals. The 3 kind of approaches that can indeed, once completely validated and approved biosafety committee of the UFMD, can be helped to ship the samples as inactivated material and also at room temperature, which will reduce the cost of shipment. And there is many papers that use these 3 approaches and demonstrate that when this kind of material arrives to the laboratory can use it to confirm FMDV by genome detection, for example, by real-time PCR or conventional PCR. Can identify the serotype, we can genotype the virus because we can also amplify the VP1 and do sequencing. Even the full genome, we can sequence the full genome. And also what is very interesting, we can transfect the cells with the RNA extracted from this kind of samples to rescue a live virus, because FMDV genome is a positive sense RNA that when it is injected into the cells, the genome is immediately translated by the cells, and you can get the virus. But this will depend on the stability of the RNA in these samples, and also the quantity of RNA. What is still need to be demonstrated is because, as you know, to have a live virus also is very important to do vaccine matching, for example, to produce a new vaccine. So the question that still now, for me, need an answer. Is the virus rescued from this kind of samples will give the same result from vaccine matching compared to the virus isolated immediately from the epithelium. So this is need to be answered, this question. So the question, it's true that all this material can be shipped at room temperature, which even only with this, we will reduce the cost because there is no dry ice, and the weight of the package will be lower, and this is reduce the cost definitely of the shipment. But if we can prove that this kind of material is safe, we can also send this kind of material as a non-infectious material, but also can be reduced more the cost of shipment. So, but this is still to be validated and approved. Another new approach that is now under development for other diseases, but there's also some investigation, ongoing investigation to try to use this approach for FMDV, is to use the drone for the surveillance or data collection of also for management of outbreak. So this drone can be used to monitor a large area of a country, but also to follow the wildlife animals, for example, and to identify potential outbreak by observing animal behavior and health indicator if this kind of drone are equipped by sensor or by thermal cameras or something like this. But also can be used to collect valuable data on the movement of animals and condition of the farm, and so on. So, and also can be used for outbreak management. That was used in Uganda, I think, for Rift Valley fever, to deliver vaccine in area that is hard to reach, for example. So this is a new approach for me that can be helped, but today the cost of drone is very high, so we have to think also about this. So to conclude, say that indeed laboratory diagnosis play an important role in the controlling of foot and mouth disease, but before the laboratory, we need sampling, we need surveillance, we need that country record the outbreak, but this is also another issue that should be addressed before laboratory diagnosis. And there is several advances that which show, like I said at the beginning when I started working on FMD, I was surprised that there is a lack of mini kits, but today we have many improvement of diagnosis, molecular or virological or even serological diagnosis. There is more improvement, but we still have a lack in reporting, sampling, and sample analysis because, as I said at the beginning, FMDB from some countries is not a priority, and there's some limitation on our resources. But the new approaches that are being developed may improve the monitoring and control of FMDB and may help some endemic country to do the control of FMD. So we need, as scientists, to continue to develop simple and also low costly methods to provide them to endemic country and to be implemented in their conditions. So another thing that for me is very, very important is that the capacity building and technology transfer should be continued. And if we need to control the disease of the laboratory side, we have to provide to the endemic country simple method and technologies to control the disease and to detect the disease. Another thing that this is addressed to the international organizations is to continue to encourage countries to report, to sample, and send samples to reference laboratory for diagnosis. And I end my presentation by thank you for your attention and all the organizations that assist us and help us on our work. And thank you.
Thank you very much, Labib, for this comprehensive overview of diagnostics today. And welcome, Nagendra, for the second talk of this forum, which will be a closer look at one of the areas mentioned by Labib, the point-of-care devices.
Thanks, Michael. Good afternoon, everyone. My talk would mostly feature what's happening in the field and how you can send divers into the iceberg to get your samples out. The laboratory sees only the top of the iceberg, but it's the divers you can dig deep and get your samples out. So this talk would talk about those divers who could help you in getting those samples for characterization. So we need to distinguish between research and reality and routine work. For the laboratories, that's the routine work. For people in the field, that's not their routine work. That's an added work for them to go and collect samples. That includes a lot of planning for them to reach to those areas and collect samples if the laboratory personnel are involved with the people in the field to go and collect samples. And often you should understand that distance is a big factor. The laboratories are in the capitals or the provincial capitals, and the samples are not near the provincial capitals. They are somewhere in the wilderness where, like Sindbad the sailor went 7 seas, 7 hills to collect something. They have to do that. It's a lot of travel, and the travel is not by air travel. It is by using the meanest of modes of transport, motorbikes, bicycles, bullock carts, trains, and buses, which nobody has done it so far. So that's the main thing, planning. And then epidemiology and laboratory team. There has to be a sync between who will do what. Of late, in those countries where we have worked, it's the same people doing the same job. When they come to the laboratory, they wear the laboratory hat, and in the sample collection place, they are the epidemiologists. We need to have a clear metadata sheet, what information to collect, because sometimes the samples reach the lab without even any information on the species from which the animal is collected, leave alone the place where the sample originates from. And this is where the LFDs and the paraphernalia comes into this thing. So this is an example of one of the places we worked. Pretty picture, isn't it? Nobody's wearing a, PPE, or what is it called, that gown that covers from top to bottom. That's good enough to work in countries where the temperature is 16, 17. You can have those PPE or Tyvek suits and work. But in these countries, the temperature is 45 degrees Celsius in a summer, and then you ask the field staff to go and collect with all those paraphernalia. We need to evolve, innovate, and then understand what's happening there. And then the team size, how big the team should be. Because in all our training programs, we have seen large teams going to collect samples. But if a large team lands up in a farmer's household, he'll be scared to bring his animal out. So that's again one thing. And then the best way to do this is devolute, share the power, share the load. Let the field staff do this. Let them do the person who's doing the initial response can send you the first sample to the lab. Otherwise, you are left with the subsequent samples, but the first index case, you don't know what it was. Because the first index case is the one that's going to tell you where the virus would have come from, the possible origins. So there is a feeling that the laboratory should only be the people who will be doing the test, because we don't depend or we don't believe in the field staff. But please don't do that. Vaccination in all those countries would have been a failure if veterinarians only would have thought, we are the people authorized to handle a needle, we will only vaccinate. We didn't do that. We trained field staffs to do the vaccination. We created vaccinators. Same way, let us produce a group of people who are committed, who can collect these samples. Let us train the field staff to do the sampling. That means they can be the first responders, and they can be the best people to send the first sample to the lab. So we should refine, improvise, and adapt to the conditions. And then, this is the famous picture from one of the Pirbright publications. Exposure, pathogen, time, and immune response. Most of the time when we reach those sites for sample collection, we are in the late exposure or antibody stage, where we are not left with any clinical samples. And even if they collect the samples and they're sent to the lab, there is no virus detected, or the PCR is negative, antigen ELISA negative, so we're not sure what the agent is all about. For the lab, it's easy to publish the result as no virus detected. But the farmer who sent those samples, the field staff who sent those samples, is intrigued. I've sent you the samples, but there's no result. He doesn't understand these curves. And then it's pH sensitive, as we know, 6 and below 6 and above 9. But the farmer who looks at these animals being suffered, they want some treatment. Antimicrobial advocacy, we spoke. The first thing the veterinarians do is mitigation of the pain of the wound. So they use potassium permanganate solution or 0.75 boric acid solution. So most of the virus is gone for you. And then there is also a big thing, treatment based on local beliefs or quacks. You saw those pictures. What's the color? It is kerosene on those foot. That means they are preventing maggot infection. So if epidemiologists or a field staff is going to collect samples from those cases, it will be negative. That means the primary responder was the first person who could have collected you the right sample. That's where the lateral flow devices come, where they can get the samples, inactivate it, and send it to the laboratory for primary identification, where molecular methods can be the first basis. Later on, you can collect other samples for antigen matching and other characterizations. So sampling windows is only very short. It is 1 to 3. So let's decide who will collect the samples, the jurisdictions, training appropriate, and authorization of appropriate staff, trust and empowerment. When COVID-19 happened, all the governments trusted us as people to do our own COVID tests and report it. And we had the faith in our reporting. If I had COVID, I did a rat test, I didn't go to the hospital. I stayed at home. So people can be trusted, so place the trust on the people. And then stockpiling and expiry, how much you can stockpile. We have seen the inequalities where these things are available for rich and countries where there is no disease because they can stockpile, but for poor countries where there is need, the cost is prohibitive. The person who cannot spend on a vaccine, how can they spend like $30 on a rattle-for device? So please consider that. Validation requirements, it's very contentious issues. Some of the kits have shown only analytical sensitivity and the limit of detection as validation. They are validated or tested using refined, defined samples as positives and negatives to determine the diagnostic sensitivity and specificity. Yes, they would provide you the test accuracy and precision, but they don't give you the actual diagnostic sensitivity and specificity as in the field condition. And most of these kits that have come into the market, they have poor field testing. Most of them are tested only in the laboratories. How many COVID tests or rats were fully validated? We don't know. Did we care about the validation requirements? Were we aware that such thing existed? And do we have an UHA-approved protocol to validate these point-of-care devices? We don't have a protocol so far. And how are we going to validate these devices in the field? So we are working with UHA through our collaborating center to write a protocol. So if some of you get the protocol for review, please review and send it back to us. Finally, what should happen in an endemic versus free scenarios? As I said, the distance between the animal and the laboratory is very, very large. The conventional samples have failed to reach the laboratories on time. That means the disease has to be identified very early and then reported early. That's where the reporting comes. Unless you identify a disease as FMD, how will they report to you? That means we need to empower the field veterinarians and the epidemiological units in the field with these devices. Do we trust them? We have to trust them. Another developments have happened, inactivation of virus using these LFDs. We had presentations in the last 2 days. We have laboratory protocols now to extract viral RNA from these devices. And following this, we can have the epidemiological investigations to get the actual tissue samples to the laboratories. We should also empower the jurisdictions and slate labs to have enough stockpiles of these field devices wherein there is no cold chain requirement. That means it can easily be transported to the laboratories. And let us also build consensus within the postal and shipment companies on how we can transfer these samples. I saw those big boxes, but the same IRTA-approved boxes for UN 2900 is also available in a small pack also for dry sampling shipment. We can explore those opportunities and have those conversations. And then regarding the free situation, Michael, it's your forte. Thank you.
Yes, thank you very much, Nagendra. And I will try to kind of look at this from the other side for a little bit. And I have to say, though, that the usual disclaimers apply to this presentation. So this is my perspective on the regulatory situation. I'm not the regulator. And the thing is, Germany is a federal state. Animal disease control in Germany is the primary remit of the individual states. And I know for sure that on some of the things that I'm going to present, there is not full consensus among all states. And some of the points that I'm going to present may also be a bit overstated for the sake of stimulating discussion in this forum. All right, so Germany. Yes, Germany has been free of FMD since 1988. And that's why it is one perspective on LFDs from a free country, not necessarily the perspective of all free countries. In Germany, the way this works is there is an Animal Health Act where it says that in vitro diagnostic tests for notifiable animal diseases can only be placed on the market after like an official authorization for such marketing has been obtained. There is a licensing authority for these in vitro diagnostic tests that is like situated at the Friedrich-Löffel Institute, the Federal Research Institute for Animal Health, but is very much an independent authority. I mean, it is separated from like the national reference lab functions and the research functions, obviously. When you apply for marketing authorization for a diagnostic test, there's a long list of things that you have to supply to the licensing authority for them to make their assessment. And of course, this includes data on the test parameters such as sensitivity, specificity, but a lot of other tests that need to be done as well. And then the licensing authority looks at this, and either like the applicant has provided enough information for them to make their decision, or they say, no, we're not fully convinced, or we want to have like an independent view on the performance of this test, and then they will hand that over to the pertinent national reference lab at the FLI to further do validation on this test. And one piece of information that may be necessary for understanding stuff that's on the later slides is that also the package insert that will be shipped together with the test is part of the marketing authorization. So that also needs to be submitted, and that is also examined by the licensing authority. So what diagnostic tests for FMD are licensed in Germany at all? I realize that this may be a bit small, but there isn't that much to see really, because the only 4 kits that are listed here are antibody tests, and 3 of the 4 are NSP antibody tests. And there is one structural protein antibody test against type O that has a marketing authorization in Germany. So what does that have to do with like improved diagnostics and point of care or anything? Why am I even up here talking to you? I am up here because at one point there was a licensed point of care FMD antigen test in Germany. So way back when in 2015, an application was made for an FMD antigen LFD to be placed on the market in Germany. At the time, I think it may have been the first commercial one available, actually. And of course, specificity and particularly the sensitivity were evaluated by the NRL back then. The sensitivity is less than the sensitivity of a real-time PCR. We all know that, but it is roughly on par maybe with the antigen ELISA. And here's just some examples. I mean, they tested a lot of dilutions of various antigens. You can get reliably positive results with the concentrated antigen, and then as you dilute it out, at some point it doesn't turn the test positive anymore. And back then, this particular product also had some issues with detecting SAT2, for example. So before we talk more about the decision that was made on this test, we should think about like what sort of like performance do you need to show to actually obtain that marketing authorization. And there is some subsidiary law in Germany that kind of explains the process and sets the bars. And when you're applying for a marketing authorization for a new veterinary diagnostic test, the level of performance that you need to show is like you have to match the state of science and technology, which under the 3 compliance levels that are available and that are listed here is actually the highest one. So the requirements there are based on the latest, greatest technical and scientific findings that you have to meet. This is a step below the mere state of the art, where you have to meet what is technically necessary, suitable, and proportionate. Then the lowest of these bars is actually the accepted rules of technology, because that requires compliance only with things or characteristics that are only widely recognized in the community and are practically proven to be able to deliver. The problem with that is, I mean, this is a statement in the law, so it's a very high-level thing, and in each individual case, what actually constitutes the state of science and technology cannot be possibly spelled out in the law. So in this particular instance, of course, the licensing authority comes to the subject matter experts, i.e. the National Reference Lab, and says, hey, what do you think? What is the state of science and technology when it comes to FMD antigen tests? And does this product meet that standard? So the NRL back then was actually quite happy with the performance of the test. But what they did was that they requested changes to the package insert. They really wanted to make sure that when the test hit the market, that it was made very clear in the insert that sensitivity of the test was limited, and that this limited sensitivity brought with it a very narrow range of suitable sample materials that can be tested. So it's only vesicular fluid and epithelial material from FMD lesions. Do not test serum, do not test milk, do not test swabs, don't do any of that. Just the stuff that comes directly from a vesicular lesion. But the manufacturer agreed to make these changes. The other bit is important as well. So if the LFD is negative, it says in the insert, you can't stop there. You have to take that negative LFD and send it to a lab, or send some more samples to a lab from the same case to have a lab follow-up. Don't rely on a negative LFD. Very important. Okay. So manufacturer agreed to make these changes, and then they did obtain the marketing authorization for their LFD in Germany. And with that came the release of one batch of actual tests. They were put on the market in 2015. Thing is, if you have this marketing authorization, anybody in Germany can buy this test. There is no legal restriction that says, oh, only official veterinarians or only state diagnostics labs can buy that. Anybody can. And anybody can then use it, anybody can then take action based on the result of this test. I mean, if you do that stupidly, of course, you open yourself up to like legal ramifications after the fact, and if they can prove in a court of law that your misuse of the test led to X amount of damages, they may want you to pay these back. But can you come up with a couple billion to pay for an FMD outbreak? All right, so that was the situation back then. For reasons that are not entirely known to me, this test is no longer being produced, and no further batches of the test have actually been placed on the market in Germany. And then the licensing authority came back and said, well, there is a legal requirement that you have to have a new batch of your test to be put on the market every X years. I think it's every 5 years. And if you don't do that, then your marketing authorization simply expires. So it just fizzled out. The test is no longer available. And to my knowledge, it was never actually used in Germany for the time that it was being technically available there. So for my opinion here, is there an actual need for such an LFD in Germany as a free country? Germany has a fairly good laboratory infrastructure. As I said, we have these, like the devolved animal disease control in the responsibility of the individual states, and they have over 20 labs distributed across Germany that can do and do FMDV real-time PCRs to rule out FMDV in certain cases. All these labs are accredited, and FLI, as the NRL, does regular proficiency tests within that laboratory network to make sure that they're actually up to speed with their FMD diagnostics. And then, and this is something that, if we have time, we can discuss here as well. Germany has this like early warning and differential diagnostic schemes that promote an exclusion of FMD infection by lab testing, even in situations that are not an official FMD suspicion. So you can send samples with not much harm done to the producer or the holder of the animals that are being sampled, and you can have FMDV excluded by laboratory diagnosis quite quickly, easily, and in many cases without any cost to the farmer. And Nagendra had, well, both Nagendra and Labib, I think, touched upon this. So we have this timeline. You have the moment where a pathogen is introduced to the farm, then some animals get sick, et cetera, and at some point the disease is identified, samples are taken, and then samples are being sent for testing or tested on site. And in my opinion, in most situations, much more time is lost between the moment that the disease was first on the farm and the moment that somebody actually realizes, hey, there is something wrong here and we need to do some sort of diagnostic follow-up. Once you reach that point, things can progress fairly quickly. Depending on the situation, sure, you can either do it on a farm, have it immediately, or send it off, but then we're talking hours or days of delay, whereas the delay between the introduction and the first recognition of something being wrong can often be weeks. So in the free situation, the only place where I see that an antigen LFD can be useful is kind of as a secondary thing in an already identified outbreak. So we already know that FMD is in the country, we already have an index case identified, and then official veterinarians go out, they look at like contact farms, farms within the restriction zones, and there, if you have a positive LFD result, that can like put your mind at ease or help you in making hard decisions about control measures, culling, etc. But keep in mind, with the restrictions about the test sensitivity and the suitable sample matrices, you're only likely to get a positive LFD result in an animal that actually has clinical FMD lesions anyway. And so if you're on a farm in an outbreak situation where you know this is a contact farm or this farm is in the same village as other identified farms and you have animals with vesicular lesions, do you really need a positive LFD in your hand to take action? I mean, there's a legal side to this, of course. There's now under the new EU animal health law are clear definitions of what is a suspect case and what is a confirmed case. And I've highlighted here, I don't know if you can read it, but to have a confirmed case, you do need a positive detection of antigen. But of course, there's also the possibility under the law that in a situation where you have a mere suspicion, but the epidemiological situation requires control measures such as culling in a suspicion situation, that can also be done. And that is something that needs to be part of a contingency plan, where the authorities have to decide ahead of time various scenarios that they can come up in an outbreak situation and what the guidance for the competent authorities in every case is. And so, as I said, I don't see much of an upside. In particular, you have to keep in mind that Germany is free, and I hope it stays free. I hope we don't have the need to have these tests used. So you would just buy batches and batches of LFDs with fairly short expiration dates. They would sit in a warehouse somewhere in a red box to be used in case of an outbreak. And then after a while they expire, you throw them out and you buy a new batch. And any other use of an LFD in a free country to me seems very, very dangerous. Because sure, you put it in the package insert that you need to follow up negative results. But I mean, that's some words on a piece of paper. Does that really compel people to do that? To me, the more likely scenario would really be that there's a veterinarian, he's got a bunch of these tests in his car, and he comes to a farm where some animals are sick, and he says, yeah, hey, I got this test, we can try it. An improper sample is being taken. For whatever reason, the LFD is negative. But then, oh, great, we have a negative FMD test. So whatever these animals have, it's not LFD. Bring out the potassium permanganate or the antibiotics or whatever. Let's try and make these animals healthy again. So I feel that the false negative results really can jeopardize the identification of an introduction, and that obviously has devastating consequences for the outbreak response, because negative results will create this false sense of security and promote what I think is counterproductive behavior. So, in my opinion, in a free country with a sound, reliable diagnostic infrastructure, an FMD antigen LFD is likely to do more harm than good. My personal opinion and the perspective for one free country. And I would really like to hear opinions from other free countries, and particularly from people who do not agree with this assessment. And I really hope that we can have a good discussion in this forum about this topic and many of the other topics that have been raised. Thank you. can I please invite all the speakers back on stage for the discussion? And Santina as well. And Melanie Chitre. Yeah.
No, stay here.
Okay. I was going to give over the floor to Melanie first as one of our panelists. Sorry, Melanie, I'm putting you on the spot. Just to get her thoughts on all of this. And I was particularly interested to hear whether or not any of these kind of new technologies that we've talked about were used when you had the outbreaks in South Africa. And if they were not used, why not, and what were some of the limitations?
Okay, so in our experience, none of these new technologies were used. We do not have the capacity in our lab. They have not been validated for the SAT serotypes. So we're just using your general conventional diagnostic assays, the solid phase competition ELISA, first line for testing, and only from a positive result, then we go further before we actually confirm the results. So we'll do molecular testing, sequencing, and that kind of things. I don't feel that LFDs would work, in my opinion, in endemic countries. I think Nagendra and Michael have touched on the reasons why. We see that for effective control in endemic countries, we need effective surveillance, we need accurate, reliable diagnostic tests and rapid responses. Sampling in the field can be very chaotic. There's no way we can take time and care to ensure that the samples are correctly done for these LFDs. So they need to be validated for samples that can be easily taken, that for one. And another aspect would be costs for the endemic country. The costs and the economic impact would really need to be researched a lot. It really has to outweigh the current situation we are facing with our diagnostics for it to be any benefit at all. Can we really rely on the field team? I know Nagendra said we should trust the field team. Let's be honest, there's a lot of corruption and bribery that happens in endemic countries. I really don't feel that these LFDs will just remain in the hands of the authorities or the people that are trained to do these testings. I really do feel with the corruptions that we face, it will go into hands of people that shouldn't have these tests. And definitely, we see that the number one cause of outbreaks is illegal movement. And if these LFDs are rolled out, I do feel that those illegal movements will skyrocket and we will have another really major situation to deal with. So I think there's many different aspects, but in my opinion, that's what I feel. Yep.
Thank you, Alejandra. Keith, I think the question is.
Yes, thank you, and sorry if I do sound a bit provocative, but thank you everyone for your talks. I was kind of hoping to hear some of the newer ideas on where the revolution in diagnostic testing might go. You know, just a couple of examples. One of the big issues in a free country is you get one outbreak and you sequence it. You get another outbreak. How many are there that we've missed? And yet back in 2010, 11, we were doing full genome sequencing. That's kind of part of your diagnostic suite. And in Bulgaria, thanks to Perbright, we were using it to show that there was an undetected reservoir of cases in wild boar. So that was control through innovative diagnostics. Again, environmental sampling. None of you talked really about environmental sampling. And yet the answer to the question in South Africa of worry about your field teams for COVID, for example, is to use use environmental sampling. Most of the population is measured for COVID through what goes through the wastewater. For milk, most of the milk in countries goes through cooperatives, creameries. You have a source and sample. So there are some ways that all these new technologies can actually be used. And finally, I think we need to be really careful we don't get rid of things like LFDs because there aren't a market for them. Because actually there are uses for them, and I've seen them being used in endemic countries, because if you have a new outbreak, and if you had a serotype-specific LFD, it would give you some information in the field that there's a new strain coming in or there's a new outbreak not controlled by vaccination. So be careful we don't destroy an international market by arguing there isn't really a market in free countries.
Any other? Okay. And then someone from the industry will be interesting to see what they think.
Okay, thank you very much to all the presenters. What we are grappling with right now in the endemic countries is what does a good FMD surveillance plan look like? You know, in the light of the fact that we're using vaccines that are not really pure. So what would a good surveillance plan for us look like in terms of the metrics that we would have to use and in terms of the tests that we would have to use considering the low resources? Thank you.
There's maybe gentleman here and then Don.
Thank you, Marino. And thanks to the presenters. Very beautiful and insightful speeches. I will just want to be biased about my own country, Nigeria, because it's also one of the endemic countries where we're battling with FMD outbreaks. To start with, none of these newer technologies are currently being employed in the field in Nigeria. I'm just seeing these things for the first time here. So thanks to GFRA for the opportunity. Yes, the last speaker talked about, no, this second before the last speaker, talked about serotype-specific LFDs. These, to my mind, will be of huge benefit to us in the West African sub-region, especially where, for example, my government has recently created a whole new ministry for livestock development. And there are present efforts in border control. Nigeria shares border with Cameroon, Ghana, Chad, Niger, and to some extent, Togo. Animals come from the north down south. Yes, there are insecurities, but the government of the day is trying her best to ensure that animals don't just move. So yes, if we have some of these newer technologies, especially where we have serotype-specific LFDs being deployed to trained field paraprofessionals or trained field veterinarians, it will go a long way in helping curtail the menace of FMD, rapid detection at the point of care level, either in form of a passive surveillance system or an active surveillance system. Whichever one it fits in, this will surely help my people and my farmers. Thank you.
Can I just ask a question back to you? And maybe if this is me speaking from a country that's free from FMD, and sometimes I don't quite understand. What's the benefit to you of knowing the serotype?
The benefit to us, just to even add to that before I even answer your question, Nigeria at the moment, farmers don't have vaccines for FMD. Not because they don't want to vaccinate, but because there are no potent vaccines in the market for them to use. Now, there are 3 major serotypes circulating in Nigeria. Where we know the serotype that is prevalent or that is about to cause an outbreak or that is causing an outbreak, it will help for rapid response to such. And hence, in answering your question, when we know the serotype, it will really help us in further downstream diagnosis of whatever serotype that's causing the challenge in the country. Thank you.
Okay. Don?
Yeah, thanks very much for the presentations. I mean, I suppose to continue Keith's sort of provocative view of the world, I'm wondering whether you're also missing another point, particularly when we're focusing in endemic settings, which is, we talk a lot about here about the particular technologies, but I think we probably also need to have a rethink about the strategic purpose of doing the testing in the first place. So, and you know, a lot of us who work in international reference laboratories will very happily receive samples for testing and report those results back. But there's not really very much purpose in terms of joining all of that up. I mean, we try to do that within the networks, but really it's trying to understand what the information is telling us and what the big gaps are, what are the strategic gaps of where sampling is not undertaken, which should be a priority. And I'd say, I mean, this is going back again, a lot of, so a long time ago, there was a recommendation from Keith and from David Payton about the amount of surveillance that needed to be done in each of the endemic pools to get a true understanding of the reality of FMD circulation in those pools. And those were numbers that I think were a little bit pulled out of the air. We really should be looking much more closely at that, the purpose of the surveillance, and trying to understand how much surveillance we really need to do. So how many virus-positive samples do we need to collect from each of the endemic pools on an annual basis to give us a really good understanding of what the disease burden is? And it links a little bit back to what we were discussing in the previous topic, which is really properly understanding the burden of disease would be incredibly helpful and would give some metrics, I think, that would be useful in the narrative to try to get funding to control the disease.
These numbers that you mentioned on, have they been met? Are they being met?
I mean, I looked to Keith, I think it was 120 samples per pool per year. And I'd say some pools meet those targets, but some pools don't meet that target on an annual basis. And of course, a lot of the samples we get are inherently very biased because they may be a collection of samples from one particular country that do a really good job with surveillance. But other countries in the location or in the neighborhood don't do such good surveillance. Mm-hmm. And so again, that I think we just, you know, within this global community, we need to properly think about how we maximize the resources we have to do this type of work.
Yeah, I want to rescue one question that Susan made about the kind of diagnostic tools that it should be used in a frame of vaccines that are not completely purified. Is that correct? I think that, I don't know, if somebody has an idea of what would be the approach in that case, that is not changing the vaccines radically. But is there any response to this kind of situation when perhaps the current tools are not that useful if you want to differentiate infected and vaccinated animals? Are there any ideas?
Excuse me, if I understood well, you said which kind of test can be used if you use unpurified vaccine? This is the question? Okay. So indeed, we always speak about DIVA tests that can be used to detect infected animals from vaccinated animals. But if we look to young animals that have between 6 months and 1 year that maybe are not vaccinated, and if we do a survey on these animals that are not vaccinated, that can use also NSP ELISA to test these animals, so we can have an idea in the circulation of the virus by using this kind of animals.
Yes, I just wanted to share two things. First, in very large countries like in Africa, endemic, for sure the LFD could be useful because they apply not regular vaccination, but sometimes just ring emergency vaccination. So it could be useful to act quickly. Another thing to answer to the general comment of lack of samples, I'm puzzled when I attend different meetings from South Asia, Middle East, Africa, Latin America. Only in Latin America, I know the livestock sector is much more organized, and you have association, powerful association, big farmers. But I'm surprised that in the other meetings, you don't have representative of farmers. And I think for participative approach, they should be invited, at least some representative, to create awareness, to be aware of the control strategy, to spread the message that there is a need to accept the sampling. And even more for the countries who are going even for the one which are advanced, which are representative. In the Panaftosad, you have the representative of farmers next to the CVO, always. You don't have any of them in the other regions. But even there, I guess in Latin America, they will be even more important because since they are stopping vaccination, they know they should accept much more active surveillance and be present and accept, yes. I know there is an economical purpose, but I think it would be useful to incorporate more, even if it's an embryo or association of farmers in these endemic countries, for you to have access to more samples.
I think we have here two different issues. We have countries that FMD is not a priority. They don't have resources to control the disease. They don't sample because they don't have resources, but it's not priority. We have another issue that countries don't want sampling. This is another issue. So the approach could be different. Even if you invite them in this meeting, they will not sample samples. And even if they send samples, they don't want that we know what happened in the farm.
Alejandro?
So, yeah, just to touch in some of the points that were mentioned before by Keith Don and some of the things that we were discussing before. So one is like, can we start thinking of some sampling using like different type of sampling, like environmental, oral swabs at different, so what are the different stages, but then also start thinking about, can we combine it with other diseases? And we start doing this as pilot in some countries, so can we test the environmental samples only, not just for FMD, but other diseases, so the surveillance can be more holistic in a way, or we can tackle more than one disease in the same surveillance, and start making some plans, different stages, different type of sampling, how can they complement each other? And then just touching back in the farmer's point, I think, yeah, that's probably a key point and something that we've seen in many countries. When you go back and give results to the farmers and start discussing some of the challenges, the engagements increase a lot. So we have kind of to give back to be a win-win and also start making the plans with them.
Okay. To the complementary to my colleague in front talked about the inclusion of the farmer organizations in such meetings. But I want to add that the private veterinary organizations should also be included in these discussions. And what Keith mentioned in the previous session, that the use of antibiotics, antimicrobials, are increased after the FMD outbreak. So therefore, the private veterinary organizations and the state veterinary organizations sometimes conflict each other because the private veterinarians make a lot of money, and so their antibiotic stocks are used after the FMD outbreaks, and they are reluctant for, informing FMD outbreaks. So therefore, they have to be included in such platforms, and they have to agree that the importance of FMD and reporting of FMD. Thanks.
Sorry, I have like here before.
Oh, perfect.
Please, sorry. This is my. Yeah, well, then he gives you the floor, so it's yours. No, it's yours. Oh.
Okay, sorry. Yeah, no, I mean, Sinan, I agree with you. There's some vested interests that would say there's more to be made from antimicrobials than from vaccinating an animal. That is true. That is a problem. But actually, my question a little bit to Mariano, Alejandro, anyone from the countries which are using regular routine vaccination. So how do you make that easier to monitor the herd level immunity? Are there diagnostic tests, we've talked about them for years, that you can use on bulk milk that will show that you have a herd level of SP antibodies that correlate well enough? The vaccine companies, you're selling huge amounts to big commercial herds in Saudi Arabia and so on. Are you providing any guidance to them as to how you monitor the SP levels to make sure that they're up there, the titers are high enough to protect at herd levels. So there's a connection of diagnostics and the decision, is my vaccine working either at country level or at the commercial level. So it's mainly for Mariano and Alejandro and anyone from South America.
As far as I know, the tests are always on serum samples. What they have developed is a single dilution liquid ELISA that allows to process a lot of samples. But I am not aware that there are other matrix where they test for antibodies. You can.
No, there's not, and particularly because sometimes when they use the milk, it stays for hours, so they mix everything, and then you get some degradation of the antibodies. So we never found a very nice correlation. If you take the sample right away, it works perfectly well, but in the bulk, it's like sometimes you don't get very good results. And the other answer, I think it should come from the
Pascal, maybe.
Pascal or someone from the vaccine producing. There are many here.
For the follow-up of antibodies, we do encourage all our customers to do post-vaccination monitoring. We're firm believers in post-vaccination monitoring. The difficulty is there's a set of guidelines, which is great. These guidelines are quite practical. The difficulty is regarding the analytical assays that are available. If the country does not have a high containment lab, they cannot use VNT. So they have to use ELISAs. And the situation outside of South America is different. The ELISAs that are available are not as correlated to protection as the South American ELISAs. So it's difficult unless you can do. You have to go for a really targeted study with a small number of animals, and you work with a high containment lab that's most of the time outside the country to do your test. But large scale, it's usually unfeasible.
I can add something to that. We are actually working on the new assays that can be used with any strain in any country and in single dilution. That is not just measuring total antibodies, but avidity of IgG1, for example, for cattle, and that works. And the idea is to move forward with that, just to try to use it in others. So that's kind of an innovation. It's not huge, but it can make a difference. Because right now, if you have a liquid phase blocking ELISA, you have to harmonize the capture and detector antibody. Then that's very difficult if you have a field outbreak and you have a field virus. It's almost impossible. But yeah.
Can we go back to Louis?
Yeah, go ahead. And I go to the back because there are more questions.
Okay. Louis has been patiently waiting for a while, I think.
Just a comment on the ELISA. The commercial ELISA usually includes an antigen that could be different from the circulating strain, or also for the strain used for the vaccine. And many customers ask why we cannot change the antigen just to be more adapted to the circulating strain or also the vaccine. The problem is that we have to revalidate. And the process to revalidate the test, it's a long process, not only for the serological test, because it's needed sample well known from experimental sera and also from field. And one of the main issues is to access to this sample, that it's very hard to obtain the sample and continues the validation of the diagnostics that is needed to set the performance if something changes.
Loic, apologies.
Yes, I will try to give some insights about industry for the diagnostics. So the first thing is maybe for us to have a clear overview of the needs and like a consensus of really what is needed. So we have this morning a very interesting discussion and debate about rapid tests, LFTs. Are they needed, useful, or not? So this is the first step for us to have a clear vision on the needs. Then there is also the question of the market size, of course, for industry. This is like the case for rapid tests or whatever. The situation is complicated with a lot of different viruses circulating. So it might be difficult also for the industry to get access to the strains and to be able to develop those tests. So then, with regard to those consideration, there is, of course, we have to take into account the market size and the money needed for the development and the production of the kit. And in such a way, the question raised is how to support R&D included from the industry. So nowadays, there is some support sometimes for some needs which are not covered to research or reference laboratories, but I'm not aware that such support is open to industry. This is the same also for collaborative projects, like there are some calls for field validations or some works which is sponsored by the EU FMD, call of interest for projects. This could be the way for us to validate some tools in the field or to get access more easily to field validations, but unfortunately the calls are not open to industry and are limited to public institutions. Michael did an interesting presentation about the situation in Germany, about tests. So I would address the question more globally of FMD-free countries, like Europe, in which case there is no, even though now there is the animal health law, changing a little bit the game, but for diagnostics there is still no mutual recognition for test approval and market authorization. So this means that we producers of diagnostics have to comply with different regulations in Europe, in all the countries. So like in Germany, I think that it's the case for NSP ELISAs. You mentioned the case, Michael, for lateral flow devices. This is not only a registration on a kit, but I think that there is also a batch-to-batch approval, which is not the same situation in other countries. So it means also that for industrial, if there is no market, it's a cost for us to register sometimes all those kits, sometimes on a batch-to-batch basis. So the question raised about the mutual recognition of one kit, which could be controlled by a lab and then leading to a mutual recognition of use in all Europe, I think could be great and beneficial for all the member states. And more widely for FMD-free countries, let's say a few words about preparedness, because if things I think are very well anticipated and organized for vaccines, I think that it is not very the case for diagnostics, because if there are vaccine banks, there are no diagnostic banks. I remember some discussions I had almost 10 years ago. I think that it was with Ewan Ryan or whatever, but about the volunteer of UFMD to discuss about diagnostic banks. I don't know where is this discussion, if it's still ongoing or not, or if it's still a project, but to ensure the availability of tests within FMD-free countries, this should be also prepared and discussed with the diagnostic manufacturers.
Thank you very much, Luc. Just a brief response to your very last question. And again, I can only confidently speak for the German situation. Germany indeed has a diagnostic bank. I mean, it's similar in idea to an antigen bank. So we're looking at NSP ELISA tests here to be used in a post-vaccination surveillance situation, where the recognition was that you may need millions of reactions of an NSP antibody ELISA in a very short time, when at the same time all the countries around you will also need these tests. And then a bit egotistically maybe, the decision was made to have a contract with a diagnostic, with a manufacturer of such diagnostic tests. You pay a flat fee every year, and in return for that flat fee, you get like dibs on a certain number of reactions of an NSP antibody ELISA to be delivered very quickly upon activation of the bank, to be used in an outbreak situation for like regaining freedom by testing of vaccinated animals. And I'd be very interested to hear if there are any other countries in Europe that have similar arrangements. I don't know.
So thank you. I'm not an expert, but I would like really to validate something with you. If we are speaking about the LFD, I see that there is some sort of concerns about its performance, while actually it could be considered as a good opportunity in the field, because this simple LFD device, and I'm not a producer of LFD, so it could give you 3 different things that you can use in it. First of all, it can give you a differential diagnosis, because it can give you black or white. Is it FMD? Is it not an FMD case? On the EU FMD website, on your own pages, you will find that you have in cattle 13 diseases that could actually conflict, or let's say be similar one way or another with FMD. So in this case, let's imagine that the veterinarian is not really an expert. The owner is not really an expert. He sees some signs in the udder, in the mouth, in whatever places, he can really confuse with FMD. Using this LFD will really help him to know either it's pan, so let's say it's FMD or not, or it's even by serotype. And when it's by serotype, this is an additional advantage, because if he will have the additional serotype inside using this, by one LFD telling him, for example, AO Asia1 or SAT1, SAT2, in this case, let's imagine that we are speaking about a country that was, for example, in Gulf, and out of sudden, 2 Kenyan workers moved from their home country to the Gulf country, and they transported with them, let's say, a new virus, like what happened before, actually, very recently. And they were surprised. They say, we have vaccines. They started to implement the vaccine, by the way, and they failed to contain the disease. Why they failed to contain the disease? Because the serotype was not there simply in the vaccine. It didn't appear that there is any response from the animals, while they believe that they are good, but they didn't realize that they have a problem until they sent the samples. It has been sequenced, identified, and then they knew that this is SAT1. So in this case, you can imagine the time between receiving the sample, between getting the sample, ship it, realize what is the problem, responding to this problem, and source the vaccine. It's a big time. It's not one day. But with the LFD, you can on the spot identify you have a new serotype that is not existing. You can really respond. And by the way, when we implement emergency vaccination, after having a differential diagnosis between FMD and other diseases, like 13 diseases, as I mentioned before, on your website on EU FMD, implementing emergency vaccine, it's not simple. It's not something that is really not very effective. I can tell in the same farm, they had before, for example, I have seen them, I have met them in a big account. In the same farm, when they implemented emergency vaccination after 24 hours from the appearance of vesicles in the animals, when they implemented after 24 hours, it just have 6 cases from the whole herd of 20,000 animals. While for the same number of animals, 20,000, and they did not realize it's FMD, and they waited for 6 days, they actually received 1,064 animals affected by FMD. You can imagine what LFD could do in this case. It will help you a lot. And last but not least, like Dr. Labib was mentioning, you can use it also as a sampling way, just 0.2% citric acid, and then you can ship it. You can understand, is it serotype, is it, for example, strain X or strain Y, strain Z? You can understand this from just a small LFD. So this device, we should not underestimate its value, especially in endemic countries. It's really very valuable. Thank you.
Labib?
Yeah, just I would like to add another advantage of the LFD. Indeed, the LFD should be used in the framework of counter strategies. Not use the LFD just for testing, say that it is FMD or not, or for endemic country that is how we know that is outbreak in all the farms, but it should be included in some counter strategies. One another advantage for me for the LFD for endemic country, and I think Don can confirm this. Sometimes you spend 3,000 or 4,000 euros to import samples or to ship samples, but at the end all the samples are come negatives. So one advantage for me for of the LFD also is to test the samples before the shipment, and you are be sure that the samples are positive, that this is also allow you to not to send negative samples, and at the end you spend a lot of money for negative samples.
Okay, if I may comment, and I will speak from the point of view of risk manager that worked a lot for the veterinary administration in free country, and to comment on the lateral flow device. Well, I think it is useful, and particularly for endemic sapiens, it has many values. But in the context of free country, you aim at early detection, you aim at early reaction. You aim to have the proper diagnosis as soon as possible. So how long it takes from the sample from the field to go to the lab, and you have the validated methods that are recognized and that are the ones that you put on the letter of diagnosis and that you notify the disease based on. It's a matter of hours. And this is the way that the free countries do. And it can be also, in a way, tricky if you go with lateral flow device and it comes negative. And farmers see this around, particularly in sensitive areas that are politically sensitive, etc. And then you get the diagnosis from the national reference lab positive. And in any case, if you have a suspicion, you always have to go to NRL. Doesn't matter what, to confirm or rule out. So it's a little bit tricky to say. And another point that Donald reminded me, and it's good to mention here, that to ensure diagnostics, timely diagnosis of FMD and transboundary and other fast diseases in the European context, particularly we focus on Southern Eastern Europe, which is an area historically considered as high risk for introduction of fast diseases. And in the scope of FAO FMD mandate, we are trying to maintain a reserve, diagnostic reserve, that can support the countries during the first weeks of epidemic, so you have sufficient diagnostic kits to cover the situation. So it's a bank that is for all countries and it can be used at the beginning. And believe me, from my experience in Bulgaria, you need to do many tests. Many tests, not only PCRs and based on clinical science, but many NSP ELISAs in the surveillance and protection and surveillance and further restricted zones. And it brings me back to 2011 when I was worked as a vet. And IUFMD provided at that time this additional diagnostic kits that really did a great job and supported the quick management and eradication of the outbreaks. And just last comment to the BIP's presentation, and thank you very much for showing the drones in terms of surveillance. We have seen how useful they can be in terms of surveillance, improving the surveillance and the efficiency of surveillance to larger scale, also maintaining high level of biosecurity, so not having many people around. And example, I think Germany is doing excellent job with African swine fever at the moment, using very modern drones and technologies to monitor the infected areas. Thank you.
I realize that time is flying by. Melanie, Don, and then Nahendra, and then we might have to call it closed.
I just want to quickly add with regards to the LFDs. It's not that I don't support it. I think that it can be very valuable, but we really need to start thinking about how are we going to roll out something like this in endemic settings, in settings where procurement is a real issue. We wait months for reagents and consumables. I can just imagine the logistical nightmare of procuring these LFDs. Are they going to be readily available for field sampling? Are there going to be shortages? Are we going to go back then to just the normal testing that we're normally doing? So we're doing LFDs and serum samples. I think we need to look into policies of how this is going to really happen. We should do maybe pilot studies where we are currently sampling as we are doing along with LFDs just to see the economical impact, to see whether it will be a benefit at the end of the day. And just to see in endemic settings how they can really benefit, because in principle it can, but when it's really out there in the field, is it going to be just a nightmare for the lab? Because Michael mentioned also that the negative samples were already sent to the lab for confirmation. I mean, in our situation, we were receiving more than 3,000 samples a month for testing, and we have very limited staff, 3 people that are doing the testing in the lab. So how is this all going to work when we're still going to have the negative samples also being sent with the LFDs? But that's just my opinion.
Don?
Yeah, I mean, I hear a lot of what's being said, and I think they're all really good and valid points. And I suppose all I'm trying to do is set a little movement here, is sort of resistance movement to say LFDs are not dead yet. And I mean, in terms of the comment from Labib, I completely agree. I mean, I think the possibility of triaging samples in the field is really valuable to make sure that good quality samples are sent for laboratory investigation, but not only triage in the laboratory, but also, not only triage in the field, but triage in the lab as well. In 2007, we had again a lot of samples coming into the reference laboratory at Pirbright for analysis. Having the LFD in the lab was really valuable because it allowed us to focus very quickly on the samples that were FMD positive, and they could be submitted quickly for sequencing. I think we've already touched, and I think your presentation very nicely sort of highlighted this new possible pipeline for sending samples from the field to a laboratory. Let's just call it not necessarily an international laboratory, but a laboratory for analysis. I think that's a really valuable pipeline that even if we move away from having to do complete inactivation of the material in the field and we still send those materials under some level of containment, it's still going to be much more cost effective than the current system where we need to maintain a cold chain. And I think that we need to really push that forward, because I think that gives us an opportunity to do a lot more surveillance in endemic settings and collect more information. And I'd say perhaps just linking to the exotic outbreak scenario as well, I also see possibilities for LFDs to help there as well. And there are scenarios where having rapid information from the field can be very informative for a CVO to very quickly define what the situation might be, notwithstanding the absolute requirement that we all understand, which is samples need to be then sent to laboratory for a proper laboratory analysis. But having a quick insight can also be very helpful.
Just a quick question back before I then hand over to Nagendra. So is the UK stockpiling LFDs for that application?
No, because we have the similar sorts of arguments that you're describing here, which are perfectly valid. But I think it's a discussion that is still active. And as you could see from the posters here presented at this meeting, we're still very much working on development of new improved lateral flow tests.
Thank you. Let me place my final arguments and plead my case before the big jury. Any technology can be misused. Mobile phones can be misused, but we all carry mobile phones. Vaccines are available through proper channels. Vaccines are also available through improper channels and applied improperly. LFDs are also same. Do you think that LFDs are not in vogue in South and Southeast Asia clandestinely? They are. People are using them. But unless you regularize them properly and give them to the proper people to do the proper tests, it'll always be there behind your mind, that suspicion of anything can go wrong. When I used to travel in Southeast Asia and work with people there, they say that we can put in mechanisms where the LFDs can be entrusted only with dependable peoples, whom they normally send for sampling. And these people are the ones who are the primary responders, and they will have the LFDs or any sampling device with them. Second thing is, for Europe and other countries, it is an exotic disease, but for us, it is an endemic disease. We have that everywhere. That means we need to routinely sample and send the samples for characterization. And then, if you want to stick with traditional sampling methods, who will prepare those buffers for us? Who would ensure that the buffers that are maintained in those areas where the people go and collect samples are still valid? Is the pH, who will ensure the pH? There is still a debate who should make those buffers, whether the laboratory should make the buffer and send it to the epidemiology unit, or the epidemiology unit itself should prepare the buffers. This argument is still continuing. So I plead my case saying that let us give the LFDs to the right people who are the first responders, so that you will get the index case, and then you will continue to get samples from the field to the lab, so that you can use these divers to dig in deep into the iceberg. Thank you.
And that's probably a very good place to stop for lunch, because I assume everyone is hungry like I am. Just to say that these are certainly not the end of these conversations that we're having today. You probably have seen me scribbling notes. I'm the official note taker for this part of the meeting. But we really hope as a GFRA that we can take all of your comments and what you've presented today and move them forward. And hopefully you'll see that through our various LinkedIn webinars that these discussions are ongoing, and especially, again, covered at our meeting next year. Thank you so much, everyone. And we will be back at 2 o'clock. I've forgotten what time it is. 2 o'clock. Thank you.